The recording. All right. So as I mentioned, for those of you that are just coming in, we are looking at testing for cancer genes in persons with glioma. So we thought we would talk a little bit about the general topic. In general, there are not many known risk factors for glioma. So genetics or family history is one risk factor. Ionizing radiation is also an important risk factor, but it's something that most individuals are not exposed to. And then also an association with the moon factor. So that's been pretty widely examined. And there's an inverse association between a history of allergy and immune factors and risk of glioma. So our focus today is going to be on genetics and family history. And so why are we doing all of this? So basically, many cancers have guidelines for whether, i.e. yes or no, and when there should be testing for cancer genes. And for cancer genes, I mean known cancer genes. So you've probably heard of BRCA1 and BRCA2, also called BRCA1 and BRCA2, which have known risk of cancers such as breast and ovarian. So when we see individuals that have a family history of breast cancer or ovarian cancer, their physician or healthcare provider might have them be tested for these cancer genes. But for individuals that are diagnosed with glioma or who have family members diagnosed with glioma, there's really no consensus guideline for whether or not these individuals should be tested or not tested. And so that is one of the things that we're hoping in our study to examine. The important thing when you decide to do this is there risk to doing this? Is there benefit to doing this? Would you be able to change people's outcome by doing this? And for germline testing, the information that we gather can relate not only to the person or the patient that we're working with, but also their blood relatives. And so some of the questions eventually we hope to answer is there any benefit to screening? Would the individual's treatment that has glioma be different? Does their outcome change? Does their response to treatment change if you know something about these germline genes? And would it change anything for family members that are blood relatives? So I wanted to introduce, I think most of you know about us, but if you don't, we thought we would just tell you a little bit about ourselves. So the International Low-Grade Glioma Registry, and we're actually almost approaching our 10-year anniversary, is an effort to try to learn more specifically about adult low-grade glioma. You probably know, especially those that are diagnosed with lower grade glioma, most of the focus in research has been on higher grade glioma, which is usually defined as glioblastoma. And so in my clinical practice, I see a lot of lower grade glioma patients and notice there really was not a lot of research in the area. So we decided to create a registry and to study specifically these individuals who seem to have different risk factors, different genes, and different outcomes. And so we started the registry. We have made an effort through funding from the National Cancer Institute to be able to offer information and inclusion in both English and Spanish. And so essentially, what is the study about? So we try to look at risk factors, be they genetic, environmental, associated with the development of glioma, but also to study what happens over time once an individual is diagnosed with these lower grade gliomas. Typically, they're astrocytomas or oligodendrogliomas, but we're also now with new information on a gene called IDH1 and IDH2, knowing that mutations in those genes are important, looking at those individuals as well. So you have to be currently, regardless of when you were diagnosed, 21 to 79 years of age. So that is typically sort of a diagnosis as an adult. You have to have a grade 2 or 3 glioma, or you actually now can have a higher grade if it's IDH positive. You can be anywhere in the world, any sex, gender, race, residence. Optimum participants are a subset of the registry. And so these are individuals that have recurrent lower grade glioma, even if on second surgery it has become higher grade, as long as initially it was lower grade. We do ask that those individuals have 2 or more surgeries, and the surgeries have to be separated by at least 6 months. And so you can go to our website. We hopefully don't ask for too much. You do have to sign a consent. We do look and confirm your pathology. We ask for a sample, and we've been moving actually from saliva to blood spots for some of the things that we're going to do, but the Ambry testing that we'll discuss later will be using saliva. And so our study has been funded by the National Cancer Institute and is called Optimum. It's part of a larger research effort called Participant Engagement and Cancer Genome Sequencing, kind of a long and complicated name, or PECGS for short. And so the idea behind these centers is that they study rare cancers or cancer in understudied populations. And so obviously for us, low-grade glioma is considered a rare cancer, meaning it's under 200,000 individuals in the United States, and obviously very understudied. So the grant is in collaboration with 2 other individuals, Bethany Kwan, who leads the study from University of Colorado, and Roel Verhaak, who is my colleague here at Yale. 3 aims, essentially to engage and enroll individuals into our study. We're attempting to have a cohort of about 400 individuals. We have about 250 so far, so we still have room for more participants. And then we're going to characterize, look at both the germline and both of the surgeries that these patients have, and look at genetic changes in the germline and in each of the tumors. And so the hope is that we can see what happens to these tumors, what happens to the genetic background in these tumors when the patient receives no treatment, or when the patient receives chemotherapy and/or radiation. And I know now a number of you are starting to be on the IDH inhibitors, given results from the Indigo trial. So we're very interested in seeing what happens to the tumors when people are on that sort of treatment. So let's talk a little bit, because we do see a lot of confusion when we mention genetic testing. So genetic testing can be either in the germline or in the tumor. The tumor is called somatic. The germline sample is usually a blood sample or a saliva sample. So germline looks for inherited genes. So genes you would have got from your biologic mother and father. As I mentioned, it's usually examined using blood or saliva. And you can use this information to inform both the person from whom you're gathering the blood or saliva, and for our study, it would be persons with lower grade glioma, but it also contains information relative to blood relatives and may inform them about their risk of cancer. Somatic genetic testing looks at non-inherited genes. And so what people typically are doing is you're looking at the tumor. So in our study, we will look at the first surgery tumor and the second surgery tumor. You can use this genetic information to inform the patient about prognosis and potentially response to treatment, but it's not used to tell blood relatives about their risk of cancer. So that's the difference between the two. And our talk today is going to focus on germline. So there have been a number of studies looking at inherited genes for glioma. And to be honest, we have not found that much so far. There are some rare inherited genetic syndromes, and we actually have seen this in our registry study, and in Optimum, we have seen a number of individuals that actually are part of these sorts of families. So you may have heard about Glioma is one rare genetic syndrome, neurofibromatosis, also known as NF1 or NF2. And so in those inherited genetic syndromes, glioma is one type of tumor that may occur. However, these syndromes explain only a small proportion of familial risk of glioma. And so what I have here, this is called a pedigree or a picture of a family. Circles are females, squares are males. A line through means the person has passed away. And so they're a way of gathering information on one or more cancers within a family. So notice in this instance, this kind of box in the middle, this person had a glioma. They were diagnosed at 31 years of age. If you move along the horizontal line, these would be this individual's brothers and sisters. So had a sister with breast cancer and a brother with glioblastoma. If you then move down, these would be the sons and daughters of this individual. This individual had a family member, a daughter who was diagnosed with glioblastoma. And so this is a family example of Glioma. These are some other syndromes. We mentioned neurofibromatosis. There's also Gardner's syndrome, Turco, and these are some of the tumors, at least of the brain, that show up in these syndromes. These are the locations where genes or chromosomal changes exist for these particular syndromes. But as I said, the majority of glioma does not appear to be explained by these rare genes. Now, I know some of you have also participated in a study called Gliogene, and I wanted to mention that as well here. We are a member of Gliogene, but this is another study run by Melissa Bondi. She's now the chair of epidemiology at Stanford, and we collaborate with her. But this is a study where they're asking for families who have more than one person affected with glioma to join to try and see if we can identify more genes associated with glioma. So if you need any information on this study, you can just contact us, glioma@yale.edu, and we'll get you on to Melissa's study. These are the members so far. I headed up the study in Massachusetts at Brigham and Women's Hospital, but we're also including it at Yale as well. So what is the risk to a family member when someone has glioma? We think that it is about 2 to 3-fold, right? So this is a little table here looking at a proband, which is an individual with glioma, what age they're diagnosed, whether they had high-grade glioma or low-grade glioma, how old the relative was, and whether they're what's called a first degree or other relative. So first degree relative means they're very close. So it would be your parents, your siblings, and your children. And if you look at the main takeaway here is this column, most of the numbers are around 2. So that is suggesting that having a sibling, parent, or child with glioma increases your risk by 2-fold. Here is an example, again, of such a family. This family is interesting because they have both a family history of melanoma, glioma, as well as some additional cancers. And the thing that is always tricky about genetic studies is some cancers in a family might be caused or associated with the gene. Other cancers might be associated with an environmental exposure. And this family is a great example of that. They have a number of individuals, right? Here's 4 individuals in the purple that had glioma, but they also had family history of lung and kidney cancer. However, these individuals turned out to be very heavy smokers. So it's likely a combination of environmental risks and genetic risks. So it can be a little difficult to sort things out. Looking at tumor versus looking at germline. So we thought we'd give a little bit of an example to help clarify how what we look for may differ by the material that we're working with. So I'm sure a number of you may carry a diagnosis of oligodendroglioma, And part of how that diagnosis comes to be is we look at the tumor and we see loss of two chromosomes called 1p and 19q, and the presence of an IDH mutation, be it IDH1 or 2. However, when we're looking at the germline, i.e. a blood sample or a saliva sample, we're looking at different things. So in these sorts of tumors, it has been found in part with our collaborators at UCSF and Mayo, that there is a change in an area on chromosome 8 that is associated, and it's a quite strong association, with a significantly increased risk of an individual having IDH mutated gliomas, i.e. oligodendroglioma. And while we believe that most oligodendrogliomas are sporadic, meaning occurring by chance, if individuals have this germline variation, right, this change in their blood or saliva, it does increase risk of oligodendroglioma. So then the question becomes, well, should we be screening people for this, right? At present, it is not recommended to screen for this variant. And so you might say, well, why would that not be something we would screen for? So there's always a couple of issues when you go to screen for a cancer or a condition. And the little example we have here, which if you're interested, comes from the paper listed below, which is free and available online if you want to look at it a little bit later. It's not only if you have the gene, what is your increase in risk, but how common is the gene? And so the comparison here is looking at BRCA1, which is quite common, and therefore it is screened for. This other gene, although if you have it, the risk is high of glioma, it is quite rare. And so both of those come into play when screening programs are put into place or recommended. The other thing that comes into play is if you know someone has a gene and therefore may be at risk of a cancer, what can you do about it? So we know for BRCA1 and 2, there are things we can do for patients to reduce their risk of both cancer and death, okay, including surgery, extended screening. We don't really have that for glioma right now, okay? So these are reasons why, although we know of some genes, there's no screening. So we are hoping to gain additional information about the role of cancer genes in glioma. And as far as we know, there's only been one other study. Again, this is available online for free. I have the link down here if you want to take a look a little bit further. So the only study that we're aware of where people have looked at cancer genes, and when I say cancer genes, there is a known list of cancer genes. It does change and vary a little bit over time, but there's kind of a standard panel that most doctors and companies will use. So this study, which was run by Chris Amos and his team at MD Anderson in Texas, looked at 152 individuals that had glioma, and they had both high and low. So it was not specific just to lower grade or IDH positive. And we feel that that is another reason why we would like to take a look at this. So it was 152 individuals with glioma. And so here's what they found when they looked for, well, what percentage of these patients have a germline variant where you might do something about it, or you might want their family members to know that this might be running in their family. So when they looked at glioblastoma, and they were IDH wild type, meaning they do not have the mutation, 13% of those individuals had a known cancer gene for which you might do something in terms of screening or treatment or telling family members. So that's pretty high. They then looked at the astrocytoma IDH mutant, that was about 7%, and then the oligo IDH mutant 1p19q co-deleted about 4%. You can see the numbers are pretty small for the lower grades. So that's one thing we'd like to do is look a little bit further at this. So in this sample, The genes that they found variants in were BRCA2, CHEK2, a little bit of BRCA1, but not a huge amount. And then some other genes here, some of which are in known cancer syndromes, and some of which relate to DNA repair. They did note that it was important to see if the glioma patient had any other cancer diagnosis. And we are seeing that as well, that sometimes a melanoma diagnosis and a glioma diagnosis might show up. And so we're seeing a relationship with the POT1 gene. Interestingly, but that is something we also want to look at, is how people did, right, in relation to survival and outcome, response to treatment, did not vary by whether they carried a cancer gene. The caveat of this is the sample size was quite small, and there weren't many individuals with low-grade glioma. So our conclusion from all of this is we need to study this more in the lower grade gliomas. So one of the things that we're able to do through our funding from the National Cancer Institute is to work with a company called Ambry Genetics, and I think a representative, maybe, as they say, standing on the line, for participants in the registry who are optimum eligible. Now, one of the questions we've already had is, why are you only testing the optimum participants? And as a reminder, these are the participants that have recurrent lower grade glioma, i.e. they have had 2 surgeries separated by at least 6 months. The short answer is that's what we have money for. We would love to test everybody, and hopefully at some point we can, but this is what we have the money for right now. So as we mentioned, Optimum is a study that's run by the registry, funded by the National Cancer Institute. And so we're looking to see how the glioma tumors change or not over time, treatment, type. And so we're trying to figure out, can we gain additional information about how do we best treat lower grade and IDH positive glioma tumors, right? As all of you know, treatments are pretty limited and there's a lot of variation. Every oncologist you go to may say something slightly different, right? You should start treatment now. Oh, maybe you should wait, right? It's not clear what the guidelines should be. So who's eligible? It's anyone currently 21 or older with these 2 or more surgeries separated by at least 6 months. And so just to give you a little bit of a feel, this is clinical level testing. So when you do research, many times you offer results, but they're at a research level, meaning that they're imperfect and they cannot be used to make a clinical decision, i.e. what steps should you go to next? This is clinical level testing of variants in inherited genes, and there's about 77 genes in the panel. This is germline testing, and most of these have been associated with cancer risk, which may or may not be glioma risk, right? It could be breast cancer, it could be anything else. So during the time of our grant, we can offer this testing for free to Optimum participants. Because it's new, I know many of you have signed a previous consent. We do. So Yale has reviewed this, has approved this, but we have to ask you to sign a new consent form. We ask you to provide a saliva sample for the testing, and we would send that in the mail. And I know some of you that have participated have already received your saliva kits. If you're in the registry and you haven't signed up for Optimum, but over time you've had a second surgery, can you sign up now? You certainly can. Just send us an email here. And if you're not in the registry or in Optimum, but you think this sounds interesting, again, just contact us at glioma@yale.edu. So what happens is the test results, we will obviously get them, but they will be available to you and whatever healthcare provider you would like us to share them with. Generally within a 6-month period, might be sooner than that, but we're, to be safe, saying 6 months. We would strongly suggest that if you join, you let us, we will only do it if you say it's okay, but strongly suggest that you let us share them with your healthcare provider because it may affect your care. You'll also get from Ambry a 1-hour telehealth genetic counseling session just to go over what do these results mean. right? If I have a gene that has a variant that might be concerning, what does that mean? So getting a 1 hour session. And then another nice benefit is if a variant of interest, right, or clinically important is found, Ambry will test your blood relatives for free for that one variant for 90 days after the participant testing. So your family members, if something is found in you that's important, they would have the opportunity to know whether it's important for them as well. And so it also helps us, right? This is a research study. We're trying to figure out what role, if any, these cancer genes like BRCA1 and 2 and POT1 have in glioma. So you're also helping our research study too, because there isn't that much known. So is there a cost to participating? No. And I just have here, I picked a copy. This is a sample of the report that comes back. I know some of you have had testing both of tumors and germlines from other companies or your hospital or healthcare institution. So you might be familiar with this sort of report. This is an example where there was a finding located in the germline. And so it talks a little bit about that, what the import of that finding is. But you would also, if you get a positive finding, have the ability to talk with the counselor. And that's why we'd like to be able to share it with your healthcare provider as well, so that they can assist you in interpreting what sometimes can be kind of complicated information. It's a multi-page report. I just did another little page here. And so for certain variants in certain cancers, again, particularly BRCA1 and 2, there are known guidelines. And so this would share, if there are guidelines, what they are with you. So you would have some awareness of, gee, this is what, they're saying I should be doing if I have this gene. So I will stop at this point. I did want to say thank you to everyone for joining us. Thank you. I know many of you on the line have joined the Register Optimum, and I just wanted to say we appreciate your efforts. You can contact us about this or anything else at glioma@yale.edu. We have our website. Everything's available in Spanish and English. And I saw Matthew Crick is on the line. I saw he's been very helpful to us in developing our Spanish materials. We are trying to have more of a presence on social media. It's been a learning lesson for all of us, but we appreciate your efforts. And so we'll now, in the next 15 minutes or so, take questions. I will